topic is on management of poor responder. Is it a fact or myth? My slide is not moving. Yeah. Okay. These are my credentials. I would like to scan all residents to scan these two QR code. One is of YouTube, in which you can see more than 200 educational videos, and one is of Orchid, in which you can see my 119 research work till date. We have got ICOG seat for reproductive medicine and laparoscopy, and Foxy recognized training for IVF, ICSI, ultrasound and laparoscopy. And we have got 2 seats of DNB in our place up to 2027. So welcome to ICOG webinar. How beautifully everything is arranged by Almighty, that as soon as child enter in this world, mother is ready to take care of it. With the blessings of Mother of Mine and so many mothers, 3 books written by us is recommended in Royal College as a reading material. Atlas of Fetal Echocardiography and Technique of IVF Made Easy has gone for 2nd edition and available in market. I am Editor-in-Chief of Indian Journal of Obstetrics and Gynecology. It is a Scopus recognized journal, and also Associate Editor in Open Access Journal in Gynecology. Worked as a KOL in diprogestone. I got opportunity to interview Professor Herman Tourney in Ashray. You can see this interview on this YouTube channel, Manish 4269. In this presentation, I would like to stress on why there is poor responder, what are the causes, how to predict it, how to manage, and lastly, point to remember. There is no definite definition of poor responder. Usually, ovarian function goes in hand with age. You all know that maximum number of eggs are there in woman or in a child at 20 weeks of gestation. Then afterwards, it doesn't increase in the number of oocytes. Every month she got more than dominant 7-8 follicles, out of which went dominant, and all this rest follicle become atretic. So woman become older, her ovarian response starts declining. Every girl is born with definite or finite number of eggs, and their number progressively decreasing with the age. So we all know that biological age matters. If somebody says I am 21 years, her ovary is of 22 years, because ovary is the first organ by the SRY gene. Then the gamete knows that whether it wants to go for female genitalia or male genitalia. So ovary is the first organ, and ovary and testes are the first organ to decide the womanhood or malehood in fetal life. So biological age always matters. As a measure of remaining number of eggs in ovary, it is called ovarian reserve. And as age ages with woman, ovarian reserve gets depleted. And we are all know that there is one hormone, that an anti-Mullerian hormone. Okay, anti-Mullerian hormone with antral follicle count gives us the idea of how is the ovarian age and what is the ovarian reserve of that particular lady on that particular cycle, because every cycle is different. How to diagnose poor responder? We have to see the antral follicle count, whether they are decreasing. What is the status of day 2 FSH? What is the size? 3, 4, 9, 8, 10, and decrease in the anti-Mullerian hormone or decrease in the AMH. On these 3 criteria, we are able to diagnose that this lady is in the classification of poor responder. With that, there is increase in the HMG, decrease in the follicle, decrease in the E2 level, and ultimately what we want, good number of oocytes. As Madam has discussed in previous case, they have got 13 different oocytes, and out of that they had freezed all on day 3 and day 5. So if you want to have good number of oocytes, there should be very good responder of the ovaries. But there is poor responder, we can get the very less number of oocytes. So in poor responder, either we can get monofollicular growth, or we can get multifollicular or superovulatory growth. So that's the dilemma. Poor responder, why should we know them? Because if we know, then we can individualize the protocol, that which protocol we have to give to the particular patients. Early initiation of treatment, if some patients come with from some another center, and we can see there is only 2 or 3 follicle after good amount of gonadotropin given, so we can not jump directly into the IVF, but we can initiate the treatment early, we can give some adjuvant which can increase the ovarian outcome in next cycle. And we can have a dare to cancel the cycle against the stimulation, and we have to counsel that if there is no proper stimulation in this cycle, we may cancel, or if there is very good stimulation but against the stimulation there is no good endometrium, or there is hyperstimulation of endometrium, or there is overgrowth of endometrium, or we can say the plastic endometrium, we have to freeze the cycle. So always counsel them regarding the stimulation, cancelling and the stimulation, or freezing all cycle. What is ASHRAE consensus on poor responders? Most recent version of this article, which is published in 2011, it says that response to ovarian stimulation in vitro fertilization, and they had done the Bologna criteria in 2021. And what is that Bologna criteria? Two of this following of three features must be present: advanced age more than 40 years, and any other risk factor of poor ovarian reserve, a previous poor ovarian reserve with less than 3 oocyte per conventional stimulation protocol, or an abnormal ovarian reserve test, that is enter follicle count less than 5 to 7 follicle, or AMH is less than 0.5 1 or to 1.19 nanometer per ml. Then comes Poseidian group. Now everybody is talking about the Poseidian or Oseidian, or it is the Greek god of water. So we know that there are 4 different Poseidian groups. In Poseidian group 1, young patient less than 35 age with adequate ovarian reserve parameter, that is enter follicle count more than 5, AMH more than 1.2, and with unexpected poor responder on suboptimal ovarian response. Then again it is divided into 2 groups: subgroup 4A, that is less than 4 oocytes, and subgroup 1B, that is 4 to 9 oocyte reserve after standard ovulation stimulation. In group 2, again lady is more than 35 years. In group 1 there is less than 35 years. And what is the difference between Bologna and Poseidian? In Bologna all the age is 40 or less than 40. Now we are talking about 35 or less than 35 with adequate ovarian response or parameters. Again enter follicle count more than 5, AMH more than 1 to 1.2 with unexpected poor response. But here in subgroup 2A, more less than 4 oocyte and 4 to 9. Only criteria is less than 35 and more than 35. In Poseidian group 3, young patients, that is less than 35, with poor ovarian reserve, with pre-stimulation parameters of enteral follicle count less than 5, again AMH 1.2 or less. In Poseidian group 4, age is more than 35 with poor ovarian reserve. So this all related with age, otherwise all the enteral follicle count and AMH, either it is more than 5 or more than 1.2. So this is a very simplified classification for poor responder by Poseidian group. So how we can predict? We all know enteral follicle count less than 5. What is the age of patient? What is the prior response of poor response in previous cycle? What is her AMH? What is the ovarian volume? Whether it is ovary is big, ovary is small, or ovary is streak-like, and what is the testosterone level of that particular patient in that particular cycle. So if required, we can give pre-cycle adjuvant in form of DHEA, or there is a cyst, we can drainage the cyst, and we can have a pre-cycle OCP. Again, this is a controversial topic. But what about DHEA, dihydroepiandrosterone supplementation in diminished ovarian reserve? This study was published in 2011, and believe me, at that time it has got very havoc that if you give DHEA, there will be very good ovarian response, and people and public are giving 75 milligram of DHEA, and now government and DCGA stop, and now they make only 25 milligram available in market in a sustained release form. So this group suggested that DHEA improves ovarian function, increase pregnancy chances by reducing aneuploidy, lower miscarriage rate. So DHEA over time is also appeared to objectively improve ovarian reserve, and people are still giving DHEA, and it has got very good result in some selected group of patients. If in cycle we can see the ovarian cyst, there are two responses: either you ignore the cyst, or before embryo transfer you can have a laparoscopic drainage of endometrial cyst less than 3 mm. Again, this is a very controversial topic. People say that 3 to 5 centimeter cyst, just ignore it, leave it there, don't do anything. One group of patients, those who are laparoscopic, they know that this is a cyst and they want to remove it. Sometimes removal of that cyst may decrease the ovarian reserve, and sometimes we can burn so many good ovaries by during fulguration of that ovarian cyst. So again, it is a controversial. It depends upon the center and depends upon the IVF specialist whether they want to go for cyst drainage prior to stimulation, or they just ignore the cyst of 3 to 5 mm in size. If it is more than 5 mm, then only thing we have to remove the cyst and we have to give stimulation after removal of that endometrial cyst. Otherwise, there will be chances of perforation of the cyst, and that may cause peritonitis. Then again comes pre-cycle OC pills, controversial topic. Again, suppression of ovarian estrogen priming. One group of thought that they are giving OC pills prior to that cycle, but a pilot study says that there is negative effect on oocyte yield after suppression of that estrogen and progesterone by giving estrogen and progesterone from outside. So de novo estrogen and progesterone from inside has suppressed, and they have got negative effect on oocyte yield. And this study was published by David H. Barrett. So what adjuvant we can give for the initiation of cycle? We can have a GnRH analog flare. We can give GnRH agonist microdose flare protocol. Gold standard agonist protocol, again in a patient in which there is poor ovarian reserve with poor ovarian outcome with antagonist cycle. So we can give old is gold. Only thing is we have to give more number of injection and cycle should be started and previous cycle from day 21, and patient has to take 20 more injection of agonist. But believe me, sometimes it gives very good result, particularly in poor responder patients. We can use clomiphene flare protocol, or we can give clomiphene and letrozole all together with gonadotropin in our patients. There is a very good comparison of mild to microdose GnRH agonist flare protocol and IVF outcome in poor responder. This study was published in 2011. They says that we recommend mild protocol in assisted reproduction technology cycle. So we recommend that mild to moderate associated reproductive cycle for response based on our result regarding less dose of used gonadotropin and shorter duration of time in stimulation. This is highlighted one, and this paper was published in 2011. Agonist versus antagonist protocol. Again, you can see there is a very good slide of. You can see that this all studies that GnRH agonist versus GnRH antagonist protocol in poor responder. Study started from 2001 to 2010. They used antagonist and agonist protocol. You see this, there is favorable protocol against the agonist, not on the antagonist. So we say that total events were 123 for antagonist and 103 for agonist, and this odd ratio favors that favors control, means antagonist cycle is still time tested and it is good for poor ovarian reserve patients. So old is gold. Then we can have a natural cycle with clomiphene and letrozole for use of IVF. Natural cycle IVF or in vitro maturation may be more desirable for poor responder patient after failure of stimulated cycle. So don't think that if there is no good follicular crop with gonadotropin, we can use still letrozole and clomiphene flare with gonadotropin in a natural cycle to get some good amount of good ovulation and good follicle for IVF or ICSI. So in poor responder, how the management protocol favors? It is a dose dependent. We can have HMG versus recombinant FSH, and recently we have heard that there is FSH polymorphism and LH polymorphism. So many times good amount of FSH or recombinant FSH doesn't yield good ovarian crop. So we have to do the polymorphism test, or empirically we can add HMG in this type of patient and we can get very good results. We have to add LH in poor responder because sometimes it is required. Always start with minimal stimulation. don't go for higher dose. We can increase the dose with minimal stimulation. We can have a natural cycle IVF. That is also a new outcome in poor responders, because after giving so many gonadotropin, let leave patient and leave her ovulation naturally, and this natural ovulation cycle you can take that ovum and you can either have ICSI or IVF depending upon the sperm concentration, and always have a dosing interval, that how much dose you have to give gonadotropin to your patients in which manner, recombinant, HMG or LH. There are people who started with 600 units. We believe that more than 450 doesn't give good, it is enough dose. Never go for 600 till date. Either you can once daily, or you can divide this 450 into 225, 2 doses. Depends upon the pulsatility of a patient. There is very good role of HMG in poor responder with recombinant FSH. I already talked about FSH polymorphism. So in this type of patient, when patient is downregulated and doesn't give good response with recombinant FSH, always add HMG to this FSH, and we can get very good follicular growth. And now it is believing that there are entities in India also, we have got FSH and LH polymorphism. Then again, there is a role of LH in poor responder, recombinant LH supplementation in poor responder in IVF patients. And this study was published in 2013. They used recombinant LH as a substitute in cycle, and they can get very good results. So recombinant LH, what is it? In recent meta-analysis of 40 randomized controlled cycle, there is significant more oocyte were retrieved and significantly higher clinical pregnancy rate were observed with recombinant FSH plus recombinant LH versus only recombinant FSH treatment in poor responder, suggested there is relatively increase in clinical pregnancy rate of 30% in poor responder, and in that addition of recombinant LH to recombinant FSH may be beneficial for women with poor ovarian response. What is the action of this LH? LH act at the follicular level in dose dependent manner and increase androgen production. Androgen are then aromatized to estrogen and help to restore the follicular milieu. Action of LH at GC level enhance the responsiveness of FSH, and LH also direct positive effect on final oocyte measure. We all know that FSH and LH both are required for ovulation maturation. That's why we want to have very good LH surge at the time of ovulation. So LH supplementation, addition of LH is always beneficial. There are randomized control by Manchester, Bosadu, Hill and Fan. They had given recombinant FSH with LH, and you see the pregnancy rate odd ratio is very good. It is increasing, so there is beneficial effect of LH supplementation with FSH in poor responder. What are the laboratory options available for us? In previous case, we had seen that they had done ICSI for all, and it is recommended when there is very low number of oocytes, and now we have got very much confidence of giving 100% fertilization with ICSI. So ICSI for all in poor responder. If we are in doubt, we have to go for PGD, because aneuploidy rates are more in this small oocyte group. So we can go for pre-implantation genetic diagnosis with PGD, and usually PGD we are performing on blastocyst level. So we are taking the trophectoderm biopsy and we are sending it for PGD, and after confirmation that this embryo is normal, then we are implanting embryo in frozen cycle or next cycle. What is the ideal day of transfer? Usually we are doing transfer on day 5th in a poor responder patients. Number of embryo, as we are implanting blastocyst, so it is a single blastocyst implantation, and if required we can take the donor oocyte for this poor ovarian reserve patients with the consent and with all necessary legal documentation. Again, ICSI for all in very small number of eggs, 3 or more than, not more than 5. It is better to do ICSI for all, and it is also recommended by ICSI in more than 4 or 4 oocytes. They believe that if you are doing ICSI for all in less number of oocytes, you are getting more fertilization rate, because since the invention of ICSI by Palmero, now everybody is confident of doing ICSI, and with ICSI we know that at least there is no chances of failed fertilization. because ICSI we are calling it is a forceful marriage. There is no choice given to ovum and no choice given to sperm bond. So we are just breaking the neck of that sperm and we are injecting that ovum forcefully into this, injecting that sperm into ovum forcefully. So there is no chances of failed fertilization, and rest we know that there is a very good fertilization rate after ICSI. Again, PGD is very much implicated in all these poor responder patients, because we all know that aneuploidy rates is very high. So better to give them chance of poor PGD and always put the blastocysts which is a normal or euploid empty. Ideal day of transfer, there are challenges. People say that day 2, day 3, or if you do day 3, day 5, there is no difference. But in poor responder, we believe that role of day 5 embryo transfer is very clear in our center. But randomized control trial demonstrating increased clinical pregnancy rate of poor responder undergoing day 2 transfer compared with day 3 transfer embryos. And this is done when there is no PGD level, because on day 2 and day 3 they are not getting very good PGD results. So usually we are transferring on day 5 and we are getting very good result. But there is a always debatable issue that whether you want to put that embryo on day 2 or day 3 depends upon the center and depends upon the IVF specialist. Day 2 embryo transfer gives best result in patient with controlled ovarian stimulation. This is a study done on 281 patients. They have done long and short GNRH antagonist protocol. On day 2 they transfer this number of patients, and day 3, but they get 11.4% more result on ongoing pregnancy rate compared to day 2 it is 21.7 and on day 3 that is 16.2. They are not compared with day 5, but day 2 transfer is very good according to Bensetti study. This study was published in 2006, but they believe that if you do it on day 2, there is also doesn't going to harm your pregnancy. Number of embryo transfer, optimizing the number of embryo transfer, they have done day 3 in 38 women or 38 year or old, and they have done day 3 transfer. This is women of 34 year age, 39, 40 and 42. These all are the patients who have got under poor number of cleavage cycle, and they are getting very good result. If there is no good ovum fertilization or no poor growth of ovum, then we can get all this donor cycle in the patient of poor responder. So next 5 year of poor responder, there will be in every X-ray there is very good discussion regarding the genomic, proteomic, metabolomics will play major role in stimulation protocol. So it is a growing stage in poor responder that we have to discuss regarding the genomic, proteomics and metabolomics. Then some people said that ovarian drilling will help. Madam says that ovarian drilling doesn't have any help. According to Madam Madhuri, there is no evidence that there is one modality of ovarian drilling superior to other. It suggests that resumption of ovarian stimulation is temporary and it can cause adhesion 0 to 100% following the drilling. So we don't recommend ovarian drilling. But there is no difference in pregnancy rate between laparoscopic ovarian drilling and gonadotropin after 6 to 12 months of follow-up. But caution should be there for laparoscopic ovarian drilling, and this study was done by in 2005. Now it is controversial whether we want to go for ovarian drilling or not. In poor responder, whether we want to go for IVF or ICSI, the thing is certain that you have to go for IVF in ICSI in small number of oocytes. What are the different protocols we can use in this poor responder? First very good protocol is GnRH antagonist protocol. Everybody knows that we are starting with 225 international unit of gonadotropin, either FSH or HMG or in combination, depends upon the FSH-LH ratio. This will be given for day 6. Then we are individualizing the dose of FSH and HMG, and we can add 250 microgram of antagonist whether on day 6 or whether there is follicle of 14 to 16 mm of size, and endometrium is very good. On the day of HCG, nothing should be given, and then should be transferred after 36 hours or 35th hour of after HCG injection. Again, GnRH antagonist protocol, 7 to 8 days after overstimulated ovulation. On day 1st, we are giving 225 international unit of percentage of HMG, individualize the dose, or patients are giving OCPs, then we can give GnRH 1.1 mg from day 21. This is a long protocol or agonist protocol, and this dose is reduced from 1.0 to 0.5 after we are starting the stimulation, and it should be continued up to the day of HCG. Only disadvantage of long protocol is more injection, because this injection she has to take every day of agonist with gonadotropin, and now with on the day of HCG we are giving nothing. So only increase in the number of injection, otherwise it is a gold standard agonist protocol, and it gives very good yield of follicle in patients of poor ovarian reserve. So what is poor ovarian reserve in IVF? Less than 5 follicle from both ovaries. Oocyte quality is not related to the number of age, but related to the woman age. Young woman with poor responder has got good quality embryos and better chances of getting pregnant. So if there is poor ovarian response in young patients, believe me, there is a very good chance with 3 or 4 or 5 follicles and 1 or 2 of very good blastocysts. Is increasing gonadotropin give you very good cycle? Increasing gonadotropin does not result in significant improvement of number of oocytes or embryo and pregnancy offset. So in our center, higher dose we are giving is 450. Usually we start with 150 and increasing to 300, and required we are giving up to 450. We are never given 600 international unit in any given situation. Sometimes we have to cancel the cycle, and we have to give the reason that after giving so many of gonadotropin there is no increase in the follicular volume or increase in the size. Then we have to give them the options. Then in next cycle we are doing this, and we must have clear-cut plan of future in subsequent cycle, that what whether we are going for FSH LH polymorphism test after giving so much of gonadotropin, or we want to give FSH recombinant plus recombinant LH, or we are giving HMG in next cycle to this patient. So everything should be clear with the patient before cancelling the cycle, and we also have to tell that why we are cancelling the cycle. So in subsequent cycle we may increase the gonadotropin dose. In subsequent cycle does not give good number of pregnancy, but we may get good number of oocytes. So what should be the maximum FSH dose? As I said, it is 450 international unit in our institute. So what is protocol? Long protocol with large doses of gonadotropin and short protocol. We can use mini dose GnRH agonist protocol. We can use clomiphene citrate plus HMG. We can have a large dose of clomiphene citrate protocol without HMG, and we can have a GnRH antagonist protocol. So we can use all different type of mix and match protocol in poor responders, and we have to see that in previous cycle whether they have got good response of ovulation with previous cycle, and then we have to judge in subsequent cycle. So always study the previous report before giving gonadotropin in the patient of poor responder. GnRH antagonists, lower total dose and shorter duration of stimulation when compared with standard load protocol. We already talked more number of injection with agonist protocol. There is less number of injections, and you can start whenever patient comes to you, or whenever patient has got 3rd, 2nd, 3rd or 4th day, you can start it. In agonist protocol you have to plan a previous cycle, but there is no difference regarding the pregnancy rate according to the antagonist and agonist cycle. You can use flare-up protocol, in which there is exogenous FSH administration. Then it started on day 3 for cycle of stimulation of follicular stimulation. Meanwhile, complete pituitary desensitization can occur. So we are giving exogenous FSH, and we can give just like long protocol, there is hypophysectomy of pituitary. So no endogenous FSH and LH production from inside, and we are giving exogenous FSH and LH, and that will give very good result of ovulation induction. We can use ultra short protocol, in which GnRH agonist is given only for 3 days with flare-up techniques. LH should be suppressed till mid-cycle, so you have to give LH suppression, and this protocol will help to retrieve more oocyte with minimal risk of premature LH surge. Lower cancellation of cycle with long protocol treatment groups. So we can use ultra short protocol in poor responders. Sometimes literature say that we use growth hormone, it may improve the number of oocyte, but no difference in pregnancy rate. Growth hormone, we all know that is expensive, and routine use cannot be justified. but in some patients we can use growth hormone, but it may give little bit increase in the pregnancy rate. Again, natural cycle, minimal stimulation with natural cycle protocol gains increased interest in lower responder. It have got comparable result with standard IVF. They are simpler and very cheaper. Just we have to give little bit of gonadotropin in natural cycle. Even after giving gonadotropins, we are getting 2-3 follicles. In natural cycle also we are getting 1 to 2 follicle. Then let's have chance of natural cycle IVF. So they are predictor for poor responder. First and almost the says if you go by Bologna criteria, it is 40. By Posadian criteria, it is 35. Day 2 FSH, estradiol, inhibin, AMH, ovarian volume, and most important is antral follicle count, because all this classification based on AFC and AMH. AMH, does it help? Definitely. The kits are available. AMH management should be most useful in prediction of ovarian response to an end ovarian removal, and it can be done on any day of cycle. And it is little bit expensive previously, but now every laboratory is getting this AMH. It exact normal level not yet or agreed upon, but every laboratory has got its standard criteria for defining good responder, moderate responder, and poor responder. So in poor responder, you can give a timed intercourse with IUI, or we can have a use gonadotropin. We can give IVF with modified natural cycle, with antagonist, with in vitro maturation. So in summary, management of poor responder depends upon the modified stimulation of protocol. Adjuvant therapy, you can give conventional agonist protocol like dampening of ovarian response to gonadotropin stimulation, mini dose protocol, stop protocol, short and ultra short flare-up protocol, microdose flare-up protocol. So we have to keep in mind of adjuvant therapy also, because lots of adjuvants available in market. So we can use as like growth hormone, androgens, soft protocols, recombinant LH, L-arginine steroids, and aspirin. People say that L-arginine, when arginine is converted into citrulline, there is formation of nascent nitric oxide, and this nitric oxide is a vasodilator. So there will be very good supply of blood to the ovarian tissue, and we can get very good ovarian growth. So it is also good. Aspirin, we all know that is antiplatelet. OC pills is still controversial, but people are using. You can use estradiol also. So management strategies for poor responder. This is a very easy slide, but you can see there is very good things. We can see that what are the management protocols. We have to customize ovarian stimulation protocol, adjuvants, gonadotropin doses, focus on quality, includes mild stimulation and high dose protocol to improve the follicular response. Dual stimulation, we can have a dual stimulation with both follicular and luteal phase with one cycle to maximize the use ID. In dual stimulation, you can it is a egg pooling also. GnRH antagonist protocol, shorten stimulation duration and reduce the risk of premature utilization, suitable for patient with low ovarian reserve. We can use growth hormone supplementation. Growth hormone may improve the oocyte quality, embryo outcome when used along with ovarian stimulation. DHEA is taken for several weeks before the stimulation. It doesn't give you instant increase, so we have to use this DHEA before stimulation, and it enhances the ovarian response in some particular patient. Coenzyme Q10 has got very good effect on sperm motility. So we can say that it is an antioxidant thought to improve the mitochondrial function and potentially enhance the egg quality. Pre-treatment with estradiol and oral contraceptive, it can synchronize the cycle. Modified natural cycle, use minimum or no stimulation. Embryo accumulation and cryopreservation, we all know that is freeze all cycle. We have to use oocyte donor when we can get nothing from this patient. We can advise lifestyle modification and energize healthy diet, exercise, quitting smoking, and improve overall reproductive health. Emotional and psychological support is not necessary in all these patients, because patient has got previous failed cycle. Everybody told that there is no good ovarian response, so we have to give them very good emotional support. So we have to give them all this TOC. Emerging treatment like ovarian rejuvenation, we can have a PRP injections. Recently, India, Dr. Surita Tendulkar has formed the Society of Ovarian Rejuvenation, and they have got very good response after stimulating that ovary with stem cells, and they are proud to have one first stem cell baby of world, by injecting the stem cell into the ovaries, and ovarian rejuvenation is there. People are injecting PRP in ovary, PRP in endometrium also. So gonadotropin, it is very good study, prospective study, retrospective study. This all study says that if you have to give good gonadotropin, or there is high versus low dose of gonadotropin in poor ovarian response, they said that if you use 6 versus 4 ampoule of this, all ampoules are coming of 75, because this is very old study. It is 2003. At that time, maximum available gonadotropin volume was 75 international unit per ampoule. So 6 ampoule is equal to 300. There is no difference in the gonadotropin set. So increasing gonadotropin doesn't give you very good yield. If you use GNS agonist protocol, we all said that is a old, is gold protocol. They had used buserelin, leuprolide. Usually they are giving leuprolide subcutaneously and leuprolide subcutaneously, and we are still giving leuprolide. These all are retrospective and prospective study from 1987 to 1999, and they say that pregnancy reference either increased 50%. So agonist protocol has got very good role in poor responder. Antagonist protocol in 2004, again this study from 1999 to 2003. Agonist protocol with, they had used CC with HMG, 600 international unit of HMG, 600 FSHN HMG with high dose of antagonist, and cancellation rate is that, but pregnancy rate is 23, it is 22, it is 22. So it is, antagonist has also very good role in poor responders. Microdose GnRH flare protocol, it is published in 2008. This is a very small study, but in two groups they have done microdose flare up protocol of GnRH agonist and multi-dose GnRH antagonist protocol. Fertilization rate is 71% and 67% in agonist protocol. So agonist protocol has got very good fertilization rate, and clinical pregnancy rate is more in agonist protocol, and in antagonist protocol it is 11.7. So again, it is believed that if you use agonist protocol in poor responder, it will give you very good result. Natural cycle, in 1999 people have started with natural cycle. You can say in one there is 19 versus no pregnancy, 14 versus 10 pregnancy. So this natural cycle is very good. In Morgia in 2004, they have got 10 patients pregnant out of 40. UTL E2 protocol, in UTL phase, estradiol you can give, and standard protocol they are not given estradiol, but you can see that embryo retrieved is more if we give luteal estradiol support. They are given in 60 patients, and they have got 3 plus oocytes compared to 2 oocytes in standard protocol. So what adjuvant we can use in this poor responder patient? First one is PRP, platelet-rich plasma. The dermatologists are used at tremendously in all hair growth patients. So PRP is usually derived from patient's own blood and injected into the ovaries. What is the mechanism? We know that growth hormones are there more in platelet-rich plasma, and they stimulate the dormant follicle and improve the ovarian function. So potential benefit is to enhance the ovarian response and improve the egg quality. It is experimental, but now we get clinical application, and more people are using. Ovarian stem cell therapy, I already told, it is there in India, and we have got ovarian rejuvenation society. Stem cell is isolated from iliac crest, injected into the ovaries for follicular development. We all know that stem cells are the pluripotent cell, and they can differentiate into ovarian cell and restoring the ovarian function. It may rejuvenate the ovary function and improve the egg production. It is also in early research, but now we have got live pregnancy with that. Autologous ovarian tissue transport, AOTT, that is ovarian tissue is removed, treated and activated dormant follicle and reimplanted into the ovaries. It reactivates the dormant follicles and stimulates the ovarian function. Potential to restore ovarian function, especially in ovarian reserve patient. It is also experimental. Exome therapy, exome derived from stem cells or other sources are injected into the ovaries. Exomes will help in cell communication and tissue repair, potentially improve ovarian function, may promote tissue repair and enhance the follicular development. It is also in research. Growth hormone supplementation, we already talked, we can give growth hormone, it may improve the ovarian response. It is also mitochondrial therapy. now we can say that we can take the mitochondria from healthy eggs and inject it into the egg of poor ovarian response. It will improve the ovarian function. Improving mitochondrial function in oocyte could enhance the egg quality and embryo development. Potential to improve the egg quality and fertilization potential. Hormonal modulation, hormonal treatment with SARMs, OC pills before stimulation. It may modulate the hormone response and sometimes give poor response. So these all are the modalities we can use in ART to improve the poor responder patients. So poor responder, it is not uncommon, it is common. On Bologna criteria, it depends on the age, risk factor and previous ovarian cycle response. We can use hormones plus ultrasound for better prediction. So many modified protocols we can use in our patients. We can use adjuvants. So there is no single breast protocol that can transfer a low responder into a high responder. The expectation should be discussed with the patient, and we should not give them the high hopes that we can get very good ovarian cope with our patients. It is preferable to opt for simpler and less expensive regime for ovarian stimulation in our patients. Main need is difficulty because they are necessary to enjoy the success, said by Professor APJ Abdul Kalam. And I am happy to share my award of Dynamic Indian of Millennium with APJ Abdul Kalam, given by KG Foundation in Coimbatore. If your work is good, we have got 119 papers published on ORCID. You can have on the GIF of so many companies. In 2016, we had published our work on diprogestone, and it is get very well publicized. So ultimately, everybody should be happy.
The time to be happy is now, and the place to be happy is here. And the way to be happy is to make someone happy
and have a little heaven right here. Thank you, ICOG, for giving me opportunity. Again, there are 2 QR codes of YouTube and ORCID. You can scan and you can have all the source of education by YouTube channel, and you can have access to all these papers. Thank you very much.
They are asking what's the role of dual stimulation in poor responders.
Yes, madam. Dual stimulation has got poor because I already said it is a ovarian.
They are asking. The question is in the chat box.
Okay, madam. Okay. Just I am stop sharing my screen.
Yeah.
Just one second. Is the question? Yes, madam. Dual stimulation. So it is a stimulation in follicular phase as well as after taking the worm. Again, we are giving stimulation in the same cycle. So it is, we can call it as the egg pooling. And by egg pooling, we can get more number of embryos. But disadvantage of that, we have to freeze the cycle, and we have to freeze all this embryo, and we have to give them at a frozen cycle afterwards. But if we are getting 2, 3, 4 eggs in the first phase, then again we are stimulating the same patient on the next dual stimulation, then we are getting very good number of probes in poor responder patients.
And I never said that you should never do laparoscopic drilling. I said laparoscopic drilling today is out of vogue according to all the guidelines.
Yes, madam.
International guidelines. But in certain patients, it may be required, especially in a place like India, where people may not have access to come for ovulation induction and monitoring, where you can do. And basically, it's only beneficial in lean PCOS patients who have a very high AMH and a androstenedione value.
Thank you, madam.
Yeah. So you said that, I said never, no. But it is not the no longer the second line of treatment. Only
Yes.
it is done because gonadotropin is a better option.
Yes, madam. How to measure endometrial volume? This questions to me, madam. There is in the chat box. How to measure? Now we have got 3D.
So that I have told ovarian volume. That was for me.
Yeah.
Ovarian volume is basically measured by the 3D method.
3D method. That is a vocal. We can say it is a vocal. VOCAL.
Rajpriya,